presentation. A very good morning to all of you. I think coming in the morning at 8 a.m. It's really difficult. So I'd like to thank all of you for joining us. I'd like to thank Vishal for including me in his session. And I think this is a very important session for especially for veterinary surgeons involving the conditions of the macula and how to dealing with them. So I'll be speaking on a taut posterior hyaloid membrane. These are my financial disclosures. So as the name suggests, taut posterior hyaloid means that the hyaloid phase has become thick, it's stretched, is adherent to the retina at multiple points. That can lead to anteroposterior and tangential traction. The main cause of taut posterior hyaloid is diabetes, and that is the one of the reasons that leads to a diabetic macular edema leading to tangential traction. And if there is anteroposterior traction, that is also leads to vitreomacular traction, that is VMT. In proliferative stages, the neovessels along with the taut posterior hyaloid and the raised neovascularization can also lead to tractional retinal detachments, which can involve the macula. Other conditions in which we can see this anomalous hyaloid membrane is in retinal vein occlusions, mainly vascular diseases. Some inflammatory conditions, trauma, Eales disease can also lead to a taut posterior hyaloid membrane. So because of its attachments at various points of the retina, at the disc and the macula, it can lead to a tractional detachment or a macular schisis. So I'll be dealing with few cases and I'll just show. So this was one of the patients which had a retinal vein occlusion. So we can see that there is a taut hyaloid membrane. Beyond that, there is also epiretinal membrane. These are different from idiopathic epiretinal membranes because they have got more glial tissue, more fibrosis, and they tend to be much more worse, and they need surgical intervention in most of the cases. So we can see that the macular contour is absolutely distorted. There is presence of a taut posterior hyaloid with some vitreomacular traction. So can you start the video, please? मैंने बताया था ना, there are 5 videos which are uploaded. वहाँ से enable कर दो ना, या वहाँ से वीडियो ऑन कर दो. नंबर 1 वाला वीडियो खोल के ऑन कर दो वहाँ से, फिर नंबर 2 खोलना. So I'm sorry with the technical fault which they are having.
Dr. Alessandro is here.
So I think we have to play the videos each time like this. So this is the case. So it's better always to stain it with triamcinolone to induce a PVD. And since the vitreous is tightly attached to the retina at various points, it's not easy to induce posterior vitreous detachment. You need multiple instruments. 25 gauge cutter is helpful. So I'm using an ILM forceps to just lift this posterior hyaloid. There are some bleeders which are there, but relatively easily you can just detach it, and this relieves the anteroposterior traction at the area of the macula. So this was followed by completion of the vitrectomy, and in such cases usually we prefer to do a ILM peeling also, a foveal sparing ILM peeling, which will also further reduce the tangential traction. I think nothing much has to be done. The surgeries are pretty straightforward, but of course there is always a risk. But the most important thing is to induce a posterior vitreous detachment, and if possible also try to do a foveal sparing ILM peeling. So in such cases sometimes the ILM is also very adherent, it comes out piecemeal, but I think in this case I was fortunate enough to peel the whole of the ILM, sparing the fovea. So that takes care of the detachment, and it takes a few months for the macular contour to come back to its normal anatomy. So can you play the PPT again, please? This is not good. So these are the post-op and the pre-op and the post-op OCT pictures, and we can see that once the surgery is done, the edema tends to resolve once the traction has been removed. So this is another case. This is a diabetic case, and we can see although the vision was quite good in this patient, the vision was 6/24, but there is presence of a fibrovascular proliferation with the taut posterior hyaloid and a bridging traction that is present in the area of the macula. So this patient was willing for the surgery because he had severe metamorphopsia. So this is really sad that you will have to play the videos again. And so what I'll do is I'll show the presentations and present all the videos together. So again, once a vitrectomy has been completed, we have to remove this tractional point. So it was attached at the disc and one point at the retina. So with the help of a cutter, you can just remove this traction quite easily. And then followed by that was followed by removal of the whole of the hyaloid face. Bleeding is common in diabetic patients, so you just have to be very careful. Sometimes even a bimanual approach with the chandelier is also helpful, although in this case I was able to remove most of the posterior hyaloid membrane with the help of a cutter only, and successfully managed dissection with the help of a 25 gauge cutter only. So once we relieve this traction, the height of the retina, which was increased, the thickness of the retina because of the traction, it tends to come down, and the metamorphopsia also settles. So we just have to take care of these bleeders so that they don't bleed in the post-op period. So although it's not necessary to remove whole of these membranes because it can lead to a bout of bleeding, once the traction is relieved, you can just leave those fibrovascular fronts there. So similarly also you can see now there are retinal folds, but the traction has been relieved. I did ILM peeling also in this case, and I'll just show you the further results. So these are the post-op and the pre-op pictures. You can see that the improvement is quite significant, and this happened within a period of 1 month. So the patient's complaints significantly reduced and the vision also improved. So this is another case. This is a video. We'll play the video in the end. This was a case which had a traumatic retinal detachment with the macular pucker. The patient was operated somewhere else, but actually the PVD was not induced, and they put silicone oil. So once I removed the silicone oil, there was presence of a this was like a self-induced taut posterior hyaloid membrane. So I'll just show you the video. Can you play the video, please? So as you can see, I put a PFCL bubble, and I'm removing this attached hyaloid face, which is present underneath the PFCL bubble. So it'll come out. I had a lot of difficulty in removing it because it was very tightly adherent. There's presence of a macular pucker. There's presence of a taut posterior hyaloid membrane. So I injected PFCL to support the posterior pole, and so that I can just proceed with further surgery since there was a total retinal detachment also. So this was followed by, this was a case in which I used silicone oil as a tamponade. I had to use a tamponade because there was presence of pucker, there were presence of multiple breaks, which was present supratemporally. So this is the membrane which will just finally come out. I think he's not playing the right video. So this was the post-op picture. You can see that there is a well lasered break and there is under silicone oil. So the traction has also reduced. We can see the layer of the silicone oil, the macular edema is coming down. So these are my last two videos which I'll be showing. As I said, these hyaloid membranes are usually present in diabetic patients. They're very tightly adherent at various points. So these are two videos where I'll be showing where I used PFCL as an agent to dissect these membranes to protect the underlying retina and to prevent bleeding. Can you please play the videos, the last two videos? So after creating a plane between the retina and the hyaloid membrane, since there was extensive membranes and a taut posterior hyaloid and risk of bleeding, I injected PFCL between the planes. So PFCL, what it happens, it helps in the membrane dissection, and it also protects the underlying retina from creating any breaks or from any massive bleed, which further prevents the surgery. So this is one technique which you can use in diabetic patients if there is very extensive fibrovascular membranes and it prevents the bleeding. And then this I just followed with a dissection with a 25 gauge cutter. So as the dissection is proceeding, the PFCL continues to seep in between the plane. It further leads to membrane dissection, and the best thing is that even all the bleeders are tamponade, so it does not lead to further bleeding. So the next video was also the same. There was the next one, please. Actually, I wanted to simultaneously play both these videos, but they are not working together. So this is also like a similar case. There was a subhyaloid bleed which was present. There is presence of this tight membrane, just trying to create a space between the retina and the fibrovascular membrane. And then I'll inject a PFCL bubble to cause the dissection, and then gently proceed with the whole of the surgery. Dissection with the help of 25 gauge cutter only. Can you just move the video a bit further? Okay, they have stopped the video. Aage. Just move the video slightly forward. So just proceeding with the membrane dissection, I've completed it. Following that, I do a pan-retinal photocoagulation. Under PFCL, even the laser uptake is much more good because it presses the retina against the RPE. Then this is followed by the removal of the PFCL bubble, and you can see that the retina is quite healthy. The bleeders are also less. This was followed by removal of these residual bleeding and membranes which were there. And since no breaks are created, although there is a traction present at the macula, there is a tractional detachment, but there is no need to inject a tamponading agent since there are no breaks created. So PFCL really helped in these cases. So I think a thick hyaloid membrane, these are the best ways which I think can be handled. So I thank you all for your attention, and I'm sorry that the videos were not working on the screen.
Thank you, Bhuvan. Any questions from the audience? Anybody would?
Thank you, sir. Nice videos. So I wish to ask, like, you peel the posterior hyaloid with forceps. So, like, is it safe, equally safe, or any time you develop complication like they say, not to peel diabetic membranes also with forceps, better to use cutter. So.
No. I always do a dissection with the help of a cutter only. But sometimes you see, it depends on the pathology. So if it is like a proliferative diabetic retinopathy case and you're directly pulling it, then there is a very high chance that it can lead to a very severe bleeding. So in a diabetic case, it is always better to use a cutter or a scissors, or you can use a bimanual approach, and you can use two instruments. So always better to dissect it first, and once it is separate from the retina, then you can use a cutter to separate it. But directly pulling a membrane can not only create a break but also avulse a vessel and lead to severe bleeding.
Yes.
So for diabetic cases, it is not good to do a pull. But in a case where there is a removal of a membrane, a non-diabetic case, probably you can just peel these membranes with a gentle tangential movement of the ILM forceps.
So can you elaborate more on foveal sparing ILM peeling, like how to safeguard the fovea and how much area you leave like without peeling?
No. So my target is to leave around 500 microns of the central fovea, 500 to 1000 depending on the size of the disc. So I always prefer to start from the infranasal area because that is the area where even if I have a injury or something, so I'm quite saved. And then the main thing is you have to create you have to make a flap, a temporal flap, and then just lift those edges from each area. So just create it either temporal or nasal. I think that is the best place to start, inferior or temporal. So that is the best place to start. You just remove a patch of the ILM and then you can just raise the rest of it. I think if you see it in a video, it will be much more better. It's very difficult to explain theoretically. I think Vishal must be showing some videos of how to lift a ILM flap and placing it over the fovea and a macular hole.
We are,